Want to give any instructions to them?
The instructions are have a good time. Please speak. I know we had a lot of discussions on email. Yeah. So we have allowed enough time for discussions. Because I think there's going to be a lot of Easter wannabe fellows that you should give them on, and maybe kind of each other, especially for them to get your success and strategies.
And it would be, Craig is going to introduce himself and then Roger Glass. Come back out and introduce the first two of you. And I'll take over and introduce the rest of you. Just be sure to hand the paper off to me.
I will.
After the first two,
We'll pass it down along.
I'll come by here to introduce the third of it. And we'll have you save all the time for all of the discussion.
Just run another. Yeah, I'll just don't.
Prompting you to ask what kind of program this patient had on your subsequent treatment. You have to be the one to tell us.
Where's that? Research office? Or I know there's all those different what's research office. Yes, excellent. You're not cheating. Well, that's next year, right?
Good morning, everyone. And we're going to get started. I will wait for some people to still come in from the morning session. My name is Craig Cohen. Welcome to my town. I'm at University of California, San Francisco, professor in obstetrics, gynecology, and reproductive sciences. And we're very glad to have you here today. I hope, looking across the audience, it looks like we have a lot of aspiring future fellows in the crowd. And this session's really meant for you to learn from our esteemed panelists of graduates of the various Fogarty-funded Global Health Fellowship programs, and then eventually to have you ask questions for them and gain from their experiences. So I am the co-principal investigator of one of the 5 Fogarty-funded Global Health Fellowship and Scholar programs called the GLOCAL Health Fellowship Program. We have carefully, the various leaders of the programs have carefully selected the panelists from amongst the large number of graduates of the programs over the years. We've brought these panelists together, so each of the 5 consortia have one representative here, and they'll be representing their consortia. In addition, we carefully have selected these panelists to coincide with the themes of this conference. So for example, we have individuals who will be talking about MDGs and SDGs, which has been highlighted here, including another on planetary health and One Health, governance, innovation and technology, So again, to highlight the roles that emerging leaders in these fields can play, and how the Fogarty-funded Global Health Fellowship programs can help to enhance the careers of our panelists. So in order to open this session and to give some remarks, we're very fortunate to have Dr. Roger Glass. He is the director of the Fogarty International Center for National Institutes of Health. Roger?
Thank you, Craig and Doug, for organizing this. You have to know that while
all of you who have children know that you never have a favorite child, but there are programs that have to be really special. And this is the one I look at. You have to smile, don't you, when you see these young and future leaders? And I think I have to smile because as I think about global health leadership, so many of the leaders of today are people who have spent some time in a lower middle income country in a research situation, have immersed themselves, and have used that as a launch point for their careers. I ended up taking my wife to Bangladesh for the first time. We ended up there for 3.5 years. When we went, my wife's a pediatrician. Her chief said, you know, you're throwing away a great career to go to Bangladesh. What are you going to learn there? And she grew up to become a chair of pediatrics and the dean of a medical school, and perhaps all because she was in Bangladesh. So there's a future for all of you, okay? And I don't want you to worry about it, but there is a future, and I think, also I think about the moon launch. You know, we have the moon launch for global health and for cancer, and when the actual moon launch occurred, and when Kennedy announced it in 1960, it seemed like a crazy idea. I mean, a really big vision. In 1969, when the moon launch occurred, men landed on the moon, it turned out that the average age of people at Houston was about 28. They were in high school when the moon launch was envisioned. And here at this meeting, we've heard all about the challenges of global health in the next century. Planetary health, would you believe? And so you're going to be the moon launchers, if you will, who are going to lead us into the future. There are a lot of old people around. They're going to lay out the problems, but you're the ones who are going to be solving them. So I'm really enthusiastic about listening to you and hearing what you're going to tell us. This program is also special because when I came to Fogarty, it was a wonderful program handled by Aaron Primack and Pierce Gardner in the front row here. And it was about 25 medical students, and it was an incredibly innovative idea. And we thought as we developed our strategic plan that we had to do more than HIV and infectious diseases, but global health in the 21st century would be the NCDs, mental health, bioengineering, planetary health I hadn't thought about, but we got to have it here. And so we've expanded the program. First at Vanderbilt, we grew it from Fogarty to Vanderbilt, and that expanded into other areas of global health in the NCD agenda. Then we moved to 5 grantees and 20 universities who were involved, and with partnerships with 18 of the other institutes and centers at NIH, and we got them all involved. So we have our first surgeons, cardiologists, diabetologists, geneticists, dentists, nurses, everybody in the NIH spectrum thinking about global health. And I think what we're seeing now is reflected in the grantees that we have. That program has expanded from 25 medical students now to about 90 people, both US and foreign, medical students and postdocs, both in MDs and PhDs, going out for a year of mentored work. So you people are all the representatives. How many of you in the audience are mentors of these people? Just raise your hands. These characters need a round of applause because they and their foreign mentors are really the ones who make this program work and keep the students on board. And I see in many of these people who will have their careers in global health. One of my greatest joys when I travel as a director of Fogarty are the number of people who come up to me and reveal to me, and I may not know them, but they reveal that they were Fogarty trainees, fellows, grantees. And it's not just youngsters like these people, but it's people like the head of the Indian Council of Medical Research, Soumya Swaminathan, or Glenn DeGray, head of the South African Medical Research Council, Manuel Espinal at PAHO. These are leaders in the world today who have been trained through Fogarty programs. So we feel that the greatest impact that we can have in the global health community is training of researchers in the global health sphere, and these are returns on our investment that will continue for your careers. So we're counting on you to do things and address the complex problems before us. And as I say, this is a huge benefit to us all. Next year at this conference, we will be starting the 50th anniversary of Fogarty and the 15th anniversary of this program. So we will be using the year to think through programs and ideas that we can use to highlight the activities of Fogarty over this period. Biggest area will be in the capacity building, where people have gone, what's the feedback. So I would ask all of you to help us and tell us your stories and record them. Ann Puderbaugh's in my front row, head of our communications, and we have career track on the Fogarty website. We'd love your essays and pictures and thoughts about how these early experiences working in laboratories in low and middle income countries will have really affected your careers and where you go next. I'm looking forward with great enthusiasm to hear your stories and what you're going to tell us about the experiences you had, the science you've developed, and the prospects you see for moving this ahead. Thank you so much, and I'm really delighted to see you all here. Smiling faces. I saw you all at the orientation. This is a year later. You look so much different. Thank you.
Thank you, Roger. Those very encouraging words. I also, before I introduce our first speaker, I do want to introduce very briefly Doug Heimberger, who's a professor at Vanderbilt University and will be co-chairing this session with me. So it's my distinct pleasure to introduce to you Dr. Marciana Arnono from the Kenya Medical Research Institute. I've known Marciana, I'm one of her mentors, I'm privileged to say, since 2008 when she started working with our program in Kenya, mine and my counterpart, Dr. Elizabeth Bakusi. And currently, Marciana will tell the story of when she was a GLOCAF fellow and results from her research and how this has catalyzed her career. She is now a PhD student in the new Global Health program, a new Global Health and PhD program at UCSF. So we're fortunate to have her here in San Francisco with us. Hopefully the weather is okay for her, but she'll give us word.
Thank you. I'm surviving the weather. So my name is Marciana, and I'm going to tell you a little bit about my project, which was done between 2012 and 2013 in Kenya, and what has happened thereafter. So I'm a medical doctor by training and currently pursuing my PhD here at UCSF. And my Fogarty-funded project was on the role of HIV/AIDS stigma in PMT failure. My mentors were Professor Cohen and Professor Bakusi, and I was also supported by Glenda Gray, who you mentioned. The major aim of my project was to determine the social, cultural, and health system factors that contribute to PMT failure in Kenya. And I was looking at our program because it's a mature program and trying to find out why are we still having a high rate of mother-to-child transmission of about 10.7%. And so I utilized a case control study design. My cases were HIV-infected mothers of infants aged 6 weeks to 6 months with a definitive diagnosis of HIV, and my controls were about 150 HIV-infected mothers of infants who are not infected with HIV. In terms of the women who were involved in my study, the average age was about 26 years, and the average age of the infants was about 4 months. The median CD4 was 521 among the cases and 559 among the controls. These two values were, the differences were not statistically significant. I found that mothers who were diagnosed for the first time in pregnancy and those ones who were non-adherent and who had had a home delivery had very high odds of mother-to-child transmission, and you can see that in the red, 2.85, 3.35, and 2.40. And I also found that infants are reported to be non-adherent to the ART, and those ones who were not given ART prophylaxis, even when it was prescribed, had also got very high odds of being HIV infected. In terms of the health facility factors, I found that women who reported not receiving HIV education or counseling, not being encouraged to involve their male partner, or not receiving disclosure assistance also had got very high odds of transmitting the virus to their infants. And among the infants, women who reported that they had not been given ART at first contact for their babies, or the providers had not followed the guidelines for prescription, and we actually went back to the charts to find out, had also got very high odds of mother-to-child transmission. I also looked at psychosocial factors, and I found that women who lacked any social support had higher odds of mother-to-child transmission. However, the other common factors like stigma, disclosure, or intimate partner violence were not associated with increased odds of mother-to-child transmission. And therefore, my conclusion was that the PMT failure in this setup was associated with several potentially modifying risk factors. The health system factors had a stronger impact than psychosocial factors on MTCT, and women who get to know their HIV status for the first time during pregnancy have a really high MTCT rate. And therefore, I recommended targeted efforts to improve adherence to PMTCT guidelines by healthcare workers to all eligible mothers, but with a focus on the women who are being diagnosed for the first time. So my plans post-fellowship were threefold. One was to use my evidence to improve the quality of PMTCT in my program, to engage in publication and dissemination of these results, and to write and collaborate on multidisciplinary grants. Post-fellowship, I was able to do an oral presentation at the ICASA conference in South Africa, where I presented the quantitative results. I also did a poster presentation at the IAS Melbourne, and this was qualitative based on interviews I'd had with clients and with providers, and was able to publish 2 publications from this work. But more importantly, and what's closer to my heart, that I was able to support the KEMRI Family AIDS Care and Education Service Program to implement a PMTCT, RRI, and a continuous quality improvement program to strengthen health systems, focusing on improving counseling for the newly diagnosed mothers, providers following the guidelines, and increasing male involvement. And over a span of 2 years, we saw that our program mother-to-child transmission rate decreased from 10.7 to approximately 5%. We saw male involvement increase from 7.4 to 54.2%, which is one of the highest in the country. And then we increased early infant diagnosis for all HIV-exposed children from 54.3% to 71.2%. And then we also rapidly scaled up integration of antenatal care, family planning, and HIV services, and achieved a rate of about 85.9% of the about 120 facilities that we support in Western Kenya. Since completing the fellowship, I have also been able to author and co-author about 20 publications, 5 as the first author, 14 as co-author, and 1 as senior author, and I'm currently working on 3 others. And so this is just a list of some of them. In terms of translating my fellowship skills into practice, I have been involved in writing a couple of grants, and I think my mentors have been extremely generous, and I'm currently PI or co-PI on 7 projects and 2 as co-investigator. My research really follows a multidisciplinary approach and cuts across different sectors, as you can see, such as community case management, and I've been able to provide the first evidence for Africa on community health workers being able to diagnose and treat pneumonia in the community using antibiotics. Previously, all the evidence was from Asia. I've also been able to incorporate aspects of food and nutrition insecurity in my work and looked at the impact of food and nutrition insecurity on maternal and birth outcomes. I have also leveraged technology as decision support for monitoring and evaluation and commodity management. And I guess I have also dabbled a little bit into the transport sector and developed a rural Uber-like transport system to help pregnant women in labor access health facilities safely and within the shortest time possible. In terms of translating my work into a policy and guidelines for my country, I now sit on several national technical working groups for child health, family planning, maternal newborn health, and I've had a really unique opportunity to translate my work into national policies and guidelines, for example, the community case management, family planning, reproductive health, and HIV, and Professor Craig Cohen and myself are actually working on a national toolkit for that. And based on this, I was awarded the 2014 Lenana Emerging Scientist Merit Award. This picture is just the system that we have developed. I know we don't have the fancy taxis that you have here, but we are using our piki-pikis, which are the motorcycles, to transport these women and get them to deliver in hospital. So what are the lessons that I have learned? I have learned specifically about publishing, that it does require commitment for time to write, and it is hard work. You have to set time for it, and it is critical for dissemination and evidence of work done. More and more countries are now demanding local evidence to be able to affect their national policies. I've also learned the importance of building teams. I've learned the importance of paying it forward by mentoring others. You only get better by mentoring. And I've been able to delegate work where I lack competency. Often we try to be the lawyers and the administrators and the drivers, but you can't do everything. I have learned the importance of mingling and networking, particularly like in conferences like this. This is where you get your research ideas and where you get people to collaborate with on your next projects. And I have learned the importance of exploring, as you can see from my work. And I think that as we've been learning that there is no one size fits all. So I think the next innovations and interventions are really going to cut across different disciplines. So let's explore. I think I also learned the need to grow slow and slow it down. So as you grow vertically, to try and get some depth and breadth into what you're learning. Patience and persistence. It took me a year knocking on a door to get my first funding, but I got it. And then, of course, the need to know when it's time to retool, and that's why I'm here doing my PhD. So my next plans are basically to complete this PhD, to publish a little bit more, collaborate more on grant writings, to pay it forward through mentorship, whether it's MPH students in Kenya or medical students at UCSF. And my first student actually just published his first paper. So in sum, I'd like to acknowledge my mentors, Craig Cohen and Professor Elizabeth Bukusi, KEMRI, Fogarty Global Health Fellowship, and to you all funders out there, that it is worth investing in African scholars. Thank you.
Thank you, Marciano. It's next my pleasure to introduce Gabriel Colbert, who is an assistant professor at the University of Illinois at Chicago in the College of Nursing. So Dr. Colbert is a nurse with over 10 years of clinical experience and providing care to persons at risk of people living with HIV across diverse settings. His research focuses on interventions for infectious disease and addiction with prison populations in the US and internationally. He has experience in both HIV and the TB global pandemics, closely intertwined in regards to incarceration and substance abuse. He has many other accolades, but I'll just be short. And again, we look forward to your presentation, Gabriel.
Okay. Not that one.
One presentation.
Got it.
There we go.
All right. Thank you for having me today. I'm happy to be here, and thanks to the organizers and Dr. Glass. Happy to be talking about something that I've been working on for the last 2 years, which is a new and emerging area, which is looking at how we bring advances that have benefited developing countries to populations that have not benefited equally from those treatment advances. My work has been in the Indonesian criminal justice system and also in Malaysia, where we're looking at a particularly challenging subset of persons living with HIV who are simultaneously addicted to opioids and also involved with the criminal justice system in those countries because of laws that criminalize possession and use of substances. Indonesia has one of the largest and most rapidly expanding HIV epidemics in Asia. It's simultaneously a country where ART coverage is very low. Fewer than 10% of people living with HIV are currently receiving treatment. and it is also a country where AIDS-related mortality has increased dramatically since 2005. Over the last decade, AIDS-related deaths in Indonesia have increased by over 400%. And so one of the questions that I'm interested in is why in a country with free antiretrovirals and a robust system of universal health care, one of the largest or the largest system of universal health care in the world, do we have a situation where people are dying from what is in developing countries a treatable illness with near normal lifespan? And a lot of that has to do with the key populations that are affected. And in Indonesia, this has been for many years people who inject drugs, although we see increasing sexual transmission now to other risk groups. So why study prisoners? Well, prisoners, especially those who have what I think of as a triple stigma. They're living with HIV, they're also people who use drugs, and now they have the added stigma of being prisoners or released prisoners. And so this results in barriers to care in the community. Also, while they're incarcerated, some of them have better access to care, but in many ways, healthcare systems in prisons globally are understaffed and have a long way to go in terms of providing the same standard of care to prisoners that people have in the community. So in 2013 and 2014, I went with a team of researchers from the University of Indonesia into 2 prisons in Jakarta, which is the most populous city in Southeast Asia and also a very densely populated city. And we went into one specialized narcotics prison that houses persons charged with drug-related offenses and one non-narcotics prison. And we recruited 102 HIV-infected prisoners using stratified random sampling from those 2 sites. As you can see, the HIV prevalence in these prisons is extremely high, around 11 to 13%, which is higher than the national average for prisons. They're also extremely overcrowded, and although you're more likely to get on ART in a prison than you are in the community, we saw that it fell below international treatment guidelines. So our sample was relatively young. Most of them were just finding out for the first time that they had HIV, and they had never lived as persons with HIV outside of prison. And it was a group with very advanced HIV. About half of them met the old criteria for initiating treatment, which is the old CD4 threshold. And about half of them were utilizing ART in prison, which was somewhat higher in our sample than in either of the prisons. One of the things we did not ask about on our survey was drug use in prison because we felt it was too sensitive. However, in the process of talking to people about their drug use before they got arrested, so many people spontaneously brought up drug use in prison that we put those questions back into the survey. And what we found was that among HIV-infected prisoners, randomly selected HIV-infected prisoners, over half had a history of injecting in prison, and 98% of that half had shared needles with 10 or more people while they were incarcerated. Whereas in the community, they were generally getting clean needles and not sharing. We asked them about the situations where they engaged in high-risk drug use and needle sharing, and they said things like, when we use drugs here, it's in the open space, it's normal, it can be anywhere, it's less clandestine in prison than it is in the community. And so we saw in some of these interviews normalization of drug use in farewell ceremonies before someone would get released from prison. So drug use was very much a part of that subculture in the prison. Methadone is available in a few narcotics prisons in Indonesia, which is something that many prisons don't have, even though it's recommended by international guidelines. When we asked about methadone, we heard things like methadone is dangerous, methadone will kill you quicker, it's better just to use heroin. So there was a lot of stigmatizing of methadone, and we had to wonder, where that was coming from in the context of a prison where there was very clearly an energetic drug economy. Narcotics prisoners were much more likely to have engaged in drug injection within prison, and some of this sort of makes sense when you think about overcrowding of people who have untreated substance use disorders and stigmatization of methadone. We also looked at HIV treatment, why people who were eligible for treatment were not receiving treatment, and they said things like, I told the doctor I don't want to take ARV because I think if it's not compatible, the skin will get blackened and burned. And indeed, what we saw in the prison was people were waiting to start ART until they were at very low CD4 levels, where they were much more vulnerable to immune reconstitution inflammatory syndrome, which indeed did result in hyperpigmentation and burning of the skin. And so these were their experiences of people going on treatment, and also people dying after they had started treatment. Also, people were starting ARVs without having methadone titrated properly, and so they were experiencing withdrawal symptoms after they started ARV, and this was discouraging people who were considering whether or not they wanted to begin treatment. And we also, that also resulted in a publication in AIDS and Behavior. One of the other things that prisoners told us was that after starting ARVs, they felt more stigmatized in the prison setting. And this makes sense if you think about the high degree of social stratification in a prison and people very quickly figuring out where they belong in the pecking order, and HIV being one more way to sort of pigeonhole people in the prison subculture. We're also came to realize that many of them had direct experiences with caring for people either in prison or back at home who had died of HIV. And so, you know, while the face of HIV in many countries is increasingly one where it's healthy people who are engaging life, in Indonesia, it's still very much a stigmatized condition because it's associated with death. And indeed, what we saw is when we followed up with the 102 that were enrolled in the study, we interviewed 34 of the 68 who were released and conducted a survival analysis, and the crude mortality was about 12.5 deaths per 100 per year. And just to put this in perspective, in the US correctional system, we measure AIDS mortality in 100,000s per year. We saw that prisoners in a narcotics prison had lower rates of survival, and when we put this into a multivariate model, we saw that being in a narcotics prison was significantly associated with increased mortality. Finally, what we're doing now is we're reaching out to patients after they have been released from prison and talking to them in their home environment, because being incarcerated is dangerous, but getting released from prison is even more dangerous. And there's increased risk of non-adherence, relapse to drug use, return to high-risk sexual behaviors, and the risk of mortality goes up after people get out of prison. So we're looking at what kinds of things can we do to help people transition from prison to the community so that they remain on HIV treatment, they remain on methadone, and they're able to reestablish themselves in the community. And one of the things that we saw was that families play a big role in social support in Indonesia and caring for people who are ill. And many of them have been estranged from their families because of drug use, but a diagnosis of HIV in many ways brings them back within the social support of their family. There's really a cultural imperative to care for children who are sick in Indonesian culture that may have really important implications for how we care for these individuals after they get released. So finally, I just want to thank my mentors, Frederick Altice at Yale University School of Medicine and Dean Kamarulsaman at the University of Malaya Medical Center. Also, my colleague Agung Waluyo at the College of Nursing at the University of Indonesia, and all my friends and collaborators at the Center for HIV/AIDS Research at the University of Indonesia. Thank you.
Very much, Gabriel, for that presentation. Yeah, go ahead and begin, I think. As Craig mentioned before, my name is Doug Heimberger. I'm at Vanderbilt University, and I feel as if I am one of maybe the few people in the world who's had an opportunity to be engaged with this program since the beginning, and from all different angles. First, as a member of the Fogarty Advisory Board, as it was being started, and Dr. Pierce Gardner, who's here in the front row, was one of the architects and initial leaders of it. And then I had a sabbatical in Zambia, which gave me an opportunity to work with Fogarty scholars and fellows on the ground and develop long-term relationships. And then when I joined Vanderbilt University, it was at the time the administrative center, the coordinating center for the predecessor to the current program. That's the Fogarty Scholars and International Clinical Research Scholars and Fellows Program. And the program is as deeply embedded in my heart as it is, I know, in yours, Roger, and all of those of us who have participated. So we really relish opportunities to show impacts and celebrate those. Our next presenter is Dr. Catherine Mealy, who was a member of the, we call it UJMT, the consortium led by the University of North Carolina, Johns Hopkins, Morehouse Medical College, and Tulane. She's now a pulmonary critical care fellow at Hopkins, and her talk on biomass fuel and health in the developing world fits into the CUGH conference themes of planetary health, global environmental health, and One Health. Catherine was not only a postdoctoral fellow during the current iteration of this program in 2014, but she was also a Fogarty Scholar when she was a medical student in 2008. And the majority of her research has been, in fact, in environmental exposures and cardiopulmonary health in low and middle income countries, particularly Peru, where she spent her Fogarty Fellowship year in Puno, running a pilot study that has now turned into a larger NIH-supported grant. So, Catherine, we appreciate your presenting to us today.
Thank you very much, and thank you everyone for being here. As this fits into planetary health, kind of for me as a physician, looking at human outcomes in environmental exposures. So I'm going to present to you today really what I did over my last year as a Fogarty Fellow that has kind of become part of my fellowship research as a pulmonary critical care fellow at Johns Hopkins. So a little bit of background about me. I got my MD from Tufts in Boston, then was at UCLA for MedPeds residency, and now I'm at Johns Hopkins. And like he said, I was first a scholar as a medical student, and this year was really productive for me in the way it hooked me into global health research. I didn't get a lot of papers out of that year, but I really got the thirst for doing this work. And it led me to apply again for the Fogarty as a fellow and do the work that I'm about to present to you today, looking at cardiopulmonary effects of biomass fuel smoke exposure. And this is all under my PI, Dr. William Checkley, who's at Johns Hopkins. So a little bit of background. We've heard a lot about burden of disease globally, and my focus is on chronic diseases. So chronic diseases are rising as a #1 cause of death worldwide, even in low and middle income countries, with cardiovascular disease leading that as a #1 cause of death worldwide. And the part that's difficult is we know what causes heart disease in the States, but what about low and middle income countries? What are the risk factors there, and how do we intervene to fix this problem? So during my year, I was able to capitalize on a large NIH-funded study in Peru and do a lot of secondary data analysis from this cohort. So during my first year of fellowship, from 2014 to 2015, I was part of over 6 publications, 4 of which are first author publications, and I'm continuing to write more first author publications from this work. And then I also designed and implemented my own interventional trial in the field while I was in Peru. And that is another subset of work I'm going to explain to you today. So I'm just going to go briefly over some of the topics that I dove into through the last year. So a little bit about the CRONICAS cohort. It's an NIH-funded study looking at pretty much cardiopulmonary outcomes across Peru and environmental and other risk factors that play into that. There's 4 different sites in the cohort. The first one is in Tumbes. It's in the northern part of Peru. It's kind of a beach town. They're agricultural. They do use biomass fuel, but they cook outside. So there's not a lot of smoke exposure. They also transport by bike or by foot, so there's not outdoor air pollution. Contrast that to Lima, which is a congested major city. The pollution's not quite as bad as China, but it far surpasses any of the cities in the United States. Then our third and fourth site are in Puno, our high altitude location. Puno has 2 sites. There's an urban center that does have a lot of traffic and old cars. So there's a reasonable amount of outdoor air pollution, similar to what we have in some of the worst cities in the United States. and that's surrounded by rural Puno, which is pretty much subsistence farming communities that use biomass fuel as a primary source of energy and fuel. So the exposures, you can see, are very different across all these sites, so it gives us the opportunity to really dive into what's driving disease at each site. And one of the first publications I was part of, we were able to pretty much characterize COPD across Peru. And we found that the prevalence of COPD is similar to that what we see in the United States. It's about 6%. The main difference is in Peru, there's only up to 3% of the population smokes. So what's driving disease here? Compared to the United States, where 20% of our population smokes, and there's a similar prevalence of COPD. And we really found the answer was in biomass fuel exposure, that and previous history of TB infections. So these are factors that are real to the developing world that we don't see as much in the States and need to be addressed. Similarly, chronic bronchitis, which is defined as chronic cough and sputum production, had very similar prevalence in Peru to what we see in the United States. But once again, it was biomass fuel exposure that seemed to be most related to increased odds ratio of chronic bronchitis in this population. We also saw that outdoor air pollution, so an urbanization and being in the dense cities with a lot of pollution contributed in this setting. In unpublished work, I'll be back in San Francisco in a month to present this at the American Thoracic Society meeting. We've also looked at the CRONICAS cohort over 3 years and looked at their lung function and how it declined over a 3-year period. And we're able to tease out risk factors that were associated with accelerated lung function decline. And there's both biological and environmental risk factors there. So we found that increased BMI, high blood pressure, biomass fuel use, and urban dwelling were all really associated with an accelerated lung function decline, which we know to be associated with increased risk of mortality. So switching gears, while I was busy waiting for the IRB, I was working on those papers. And once it came through, I was able to roll out my study and get started in the field. So my study was housed in rural Puno. So it was one of the 4 sites there. So I wanted to capitalize on the fact that this is an area with high indoor air pollution exposure, see if we can intervene on it, reduce exposures, and see if it has an effect on healthcare outcomes. Like was mentioned, this work was it was a pilot study, but it ended up being the feasibility trial that I helped my mentor, Dr. Willem Checkley, write a grant for. And we were funded to scale up my Fogarty project into a larger 200-person study, for which I'm a co-investigator, and I'll be running the field cardiopulmonary outcomes for. So a little bit about that work. My study enrolled 60 people from the community. I randomized the community to either be in the control arm and use their old stoves, or the intervention arm and receive an improved cook stove. Now, at the end of the study, everyone got the better stove, but as far as monitoring our outcomes, we wanted to see if we could significantly reduce indoor air pollution by using locally appropriate interventions. Would this affect cardiopulmonary disease? The metrics we looked at were, from a respiratory perspective, we had questionnaires. For the environmental component, we were looking at particulate matter exposure and carbon monoxide exposure. And then from a cardiovascular standpoint, we monitored blood pressure and something called endothelial function. Now, endothelial function, it could take hours to explain, but to sum it up, it's basically a short-term marker for long-term cardiovascular risk. The method we used was ultrasound visualization of the brachial artery to see how it reacted to stress. And this was a technically difficult study that I had to learn. I went to Cincinnati Children's, a major center for endothelial function research, and I learned this technique, and then I brought it to the field in rural Puno. So during my year there, I was on the ground organizing all the data collection, performing the tests, but also capacitating the team to do this in my absence. As I came back last summer to run the study remotely, I've been able to really just stay in contact with short trips to continue the data collection from far away in Baltimore all the way to Peru. So this is me performing the tests and one of our participants, and this is Gelke, one of our main study nurses, who has become an expert as well in endothelial function, and she will be participating in our next study and performing this in the field. So unfortunately, since the data just came in earlier last month, I'm just getting it all together, and you'll have to wait for a publication hopefully later this year with the results from this study. It was an incredible experience to learn how to run a field intervention trial, be in the field doing it, and then step back and learn how to do it from afar and really manage people in both settings. Like I said, it's now used. This was pilot work and feasibility trial for what is now a gas versus traditional stove study that we're starting this summer and gearing up for. And one of the largest components of this is we really want to demonstrate that any intervention we're doing is sustainable and doesn't cause an extra burden to the community or health. So I've really benefited from the collaborations of these studies, working with environmentalists, behavioralists, and other anthropologists. And this is what really ties it into planetary health. Not only am I focused on getting the cardiopulmonary disease burden down in this setting, but how does it impact the community around it? So we have a large team to look at the study of 200 people moving forward in Peru. And as far as personal steps, I had a lot of opportunities to mentor undergraduate and graduate students while I was in Peru the first time around. And moving forward with this larger study, I'll be mentoring a large team of graduate students and our field site workers. And working up to knock on Fogarty's door again. I'll be applying for a K application, hoping to use a lot of this work moving forward to the next steps in my career. And really, none of it would have been possible without having time, an extra year, to do this research, to set it up, so that as I continue with my medical training, I can still continue to keep my foot in the research door and continue to move forward with these projects. So I want to thank the Puno team. This is just a section of the team. They're great to work with. My mentor, Will Checkley, UNC and my consortium have been incredible, and the Fogarty. From 2008, when I got turned on to the idea, to now, it's been a huge part of my career development, and really couldn't do it without that support. So thank you very much for your time, and I hope you enjoy the rest of the conference.
Catherine, that's really marvelous. Thank you so much for sharing that with us, and it's a real encouragement for us to see all of that. I'll invite Dr. Barclay Stewart to step on up and work on the slides there. Dr. Barclay Stewart was a fellow with the Northern Pacific Consortium, which includes the universities of Washington, Michigan, Minnesota, and Hawaii. And the title of his project is now a trauma care system assessment in Ghana, creating a roadmap for development. It fits into the CUGH conference theme on governance, which is indeed something of great interest to Barclay. He is a general surgery resident at the University of Washington now, but also has a degree from the London School of Hygiene and Tropical Medicine. And he works in Ghana and Geneva as a Fogarty Global Health Fellow and a World Health Organization intern. His research has been focused on trauma systems development in low and middle income countries and trauma care during humanitarian crises. He already has quite a track record working in Belize, Nepal, Malawi, Kenya, and South Sudan, and so he's passionate about patterning or working with ministries of health and NGOs to improve trauma and burn care in developing countries. Barclay.
Thank you so much. I'm a three-time Fogarty repeat offender, so this program is extremely dear to my heart as well. And I'm privileged to be on this panel with my friends and colleagues. So briefly, I'll highlight the injury burden and the impact or potential impact of trauma care systems, particularly in low and middle income countries, give a few snapshots of our work over the past couple of years, and describe our system level assessment in a bit more detail, as well as proposed next steps for our work there. So each year, around 6 million people die from injury. It's become the leading killer for adolescents, older teenagers, and young adults around the world, particularly in low and middle income countries, in part due to the rising urbanization and motorization, but also ongoing violence. And more than just the deaths, for each person who does die from injury, around 20 to 50 more individuals will be disabled, some of which permanently. And that, of course, exacts a large economic toll on individuals, families, and their societies. Unfortunately, despite this enormous burden of disease, there's been inadequate funding and political will, both nationally and internationally, which, when coupled with a lack of legislation and governance, has led to very disorganized and ad hoc systems that result in insufficient workforces and resources, which beget poor access to care for patients, particularly when we talk about the timely need for access to care after injury, which therefore leads to substantial avertible death and disability. Unfortunately, there is lots that we can do to save the lives of those who are injured. If we were to bring trauma care systems in low and middle income countries to the level of that which we have the privilege of existing around in high income countries, we can save about 35% of the 5.1 million seriously injured people who die each year, which is just around 2 million people a year. There's many examples of these from lots of low and middle income countries who have taken the initiative to develop trauma care systems, but for brevity, I won't go into it. So we in Ghana developed a three-pronged strategy for assessing the trauma care system: a population-level assessment, a facility-based care capacity assessment, and then how the legislation, regulation, and interfunctionality of trauma system components beget a coordinated, organized trauma system. So our population-level assessment was based upon data from the 2010 census, which we population adjusted to 2015. OpenStreetMap, road networking data, corresponding speed limits from the National Highway Authority, background speed limits of walking speed, and then the trauma care capacity of facilities nationwide. We took all district, regional, and tertiary hospitals and included it into our cost distance modeling. We divided trauma care into basic, intermediate, and advanced, where basic is resuscitation only, essentially, first aid care. Intermediate is that plus damage control surgery, typically non-operative orthopedic care. And advanced is comprehensive trauma care and surgical services. So we found that about 58% of the country can access basic trauma care within an hour. And 58% seems like a reasonable number, but it's only 58% of the country can receive any trauma care within an hour. And when we're talking about trauma, you've heard much of the golden hour, so the risk of death is significant, even for smaller injuries that could be readily treated with quick resuscitation. And only a third of patients can access advanced trauma care within an hour, which is what's needed for those with serious injury. So we went to the ministry all excited about our findings, and they were like, yeah, who cares? So what? So we went back to the drawing board a bit and identified a way to do location allocation modeling and identify facilities that, if strengthened, would improve population-level access to care the most. So we identified hospitals, or facilities, I should say, with no trauma care capacity, and if we brought them to basic care, what that would impact the access to care. Same thing with intermediate and advanced. And we did 15 for basic, 10 for intermediate, and 2 for advanced. And by doing so, we used for reasons that are a bit political, we used the 2-hour access to care, not 1-hour access to care. And the difference when adding those, or strengthening those facilities, not adding new facilities, just improving trauma care resources and training, you get about a 6 to 10% increase in access at each level, which corresponds to between 1.7 and 2.9 million additional Ghanaians at each level of care. So then we went and said, okay, well, now that we know we need to strengthen X, Y, and Z facilities, how do we actually need to do that, and what interventions need to be done? So we used the World Health Organization's guidelines for essential trauma care to adapt a tool to assess resources and services for trauma care. We assessed 40 hospitals, purposely sampled for several reasons, countrywide. We used key informant interviews and direct inspection at each hospital to get an understanding of what trauma care capacity looked like and the problems that it faced. So we used a rating scheme that's been commonly used before us, where 0 was that the resource had never been supplied, it wasn't available at any point in time, and 3, that it was available and used when needed. So you can see in the green, the basic and advanced airway equipment, that some resources and services were quite readily available with a median rating of 2 or 3, but within each hospital level, so district, regional, and tertiary hospitals across the top, there's significant variation from 0 to 3. So there are many district hospitals where you would go and wouldn't find any way to control an airway, for instance. And other very extremely low cost, but very high value added items like chest tubes and, of course, capacity to insert the chest tube was essentially not available outside of tertiary facilities. and I highlighted the blood transfusion ability at the bottom, and that's a very complex process that is much more resource intensive and costly than things like chest tube, which one could argue is quite or equally as life-saving. So it demonstrates that the supply chain is there, that the human resources and the infrastructure can be there with political will and funding. Blood transfusion, of course, benefited from much more vertical programming. For surgical services, major trauma surgery, orthopedic surgery, and basic neurosurgical care were essentially not available anywhere in the country outside of a few tertiary centers. So then we took a further step to see what factors were contributing to these deficiencies so that we could address it as a research team and with the collaboration with the Ministry of Health. And for most things, the top 3 causes of contributing factors were equipment absence, which for us meant that the ministry had never supplied it to the hospital whatsoever. That was followed by poor supply chain management practices, and then, of course, lack of training. So since that, we've developed and have started studies to address these issues, namely with strong advocacy with the Ministry of Health, a training program that's currently being developed and will be rolled out once my counterpart goes back to Ghana later in the fall, and then a study about supply chain management and how we can improve specific resiliency features of it. So we compared our data to a study that was done by Professor Robert Kwanzaa, who was responsible for developing and inspiring the guidelines for essential trauma care that the WHO produced. And we used the same rating system so we could compare over time. And a decade ago to now, there's been significant improvements in the trauma care capacity at facility levels, indicated by the bars to the right. I guess, yeah, you're right of 0. Some resources haven't changed much, and as you can see, some have actually gotten worse. So the coordination, legislation, regulation of resources and how they're supplied and the financing of it was something we felt like we had to address. So we teamed up with the World Health Organization and did an end-to-end pilot of the new emergency care system assessment tool, which is a survey designed to seek input from major stakeholders in the emergency and trauma care system nationally and identify weaknesses as well as strengths and the multiple components of emergency care systems, such as organization, governance, finance, data management, quality improvement programming, pre-hospital facility-based care, rehabilitation, and emergency and disaster preparedness. We pulled together all the major stakeholders in the country, had them all complete the tool, and then developed a working group where we were able to identify specific action priorities from system gaps we identified and implementing partners that we just needed to better utilize, as well as mobilization of existing resources without no understanding that we're not going to have this pipe dream of a new funding stream for trauma care. So this happened in the past week and a half, or 2 weeks ago, I guess. So we are currently drafting the implementation and roadmap strategy with the Ministry of Health. The action priorities and implementation plan are going to be unveiled at the Ghana Health Summit, which is where the Parliament, the executive branch of the government, and the Ministry of Health and its partners will meet. It's the first time that emergency care or trauma care has specifically been given space in the agenda. And then we have already started and will continue to have interventions and capacity building programs that address the action priorities specifically addressed in the implementation plan. I'd like just to point out a couple things that I think is pretty amazing about Fogarty and how it's been so effective in Ghana particularly. It's been a very long time where our collaborators at the University of Washington with Fogarty's support has been able to work and build research capacity in Ghana. Of course, in Seattle, Joe Zunt and Nicole Hobbs have been instrumental in organizing all of our efforts. But my good friends and colleagues, Adam Jadu and Godfred Boache, they're both Fogarty Corti recipients, surgeons, and planning backgrounds that are now going to be able to do a lot of work in the injury prevention and trauma care realm. The now head of policy planning, management, and monitoring and evaluation for the Ghana Health Service, Anthony Ofosu, was a Fogarty previously as well, and even in the Road Safety Commission, and et cetera. So the Fogarty, the benefits of Fogarty in the multi-sectors throughout the country have now been able to kind of coalesce and work together to improve trauma care from the multiple facets that it requires. So thank you all very much.
Thank you very much as well, Barclay, for that. It's very interesting, fascinating, and to see work happening at that level of health systems and governance, which we all know is very, very important. Our final speaker is Dr. Stephen Sumner, who is a medical epidemiologist with CDC's Research and Evaluation Branch in the Division of Violence Prevention. He completed medical school at the Medical College of Wisconsin and then internal medicine residency at Duke University. He also holds a Master of Science in Global Health from Duke. And his Fogarty supported fellowship, which came through the consortium called Vanderbilt, Emory, Cornell, Duke Consortium, took him to Tanzania as a fellow and conducting international injury research as well. Following his Global Health Fellowship, he served as an Epidemic Intelligence Service Officer with CDC's Division of Violence Prevention, leading field investigations in violence and crime prevention. At CDC, he has worked extensively with the Violence Against Children Survey Team, which conducts national-level household surveys across the world to improve the prevention and response to violence against children. His title, as you see there, is Advances in Preventing Childhood Violence. Thank you, Steve, for joining us.
Thank you, Doug. Thank you all for the invitation to speak with you today. As Doug mentioned, I'm a medical officer with the CDC's Division of Violence Prevention, and today I'll be talking specifically about some of the work I've been doing since my Fogarty Fellowship. As a brief background, my interest in injury prevention actually began in medical school, and it was something that I continued throughout my residency at Duke and into my Fogarty Fellowship at Tanzania. For my Fogarty project, I designed and implemented a cluster randomized controlled trial in the area of road traffic injury prevention in Tanzania. After my Fogarty Fellowship, I joined CDC's Division of Violence Prevention, which is where I continue to work today as a full-time staff epidemiologist. Today, I'm going to focus specifically on my work with CDC's Global Violence Against Children Survey Team. 10 years ago, there simply was no standardized surveillance system for childhood violence covering entire countries. In other words, in general, it was impossible for countries to know how many young people had been affected by violence in that country and what that violence looked like. Now, a lot of you don't work on violence or think about it routinely, but over the past couple decades, a host of researchers have continued to produce evidence that experiencing violence as a child leads to a large number of subsequent downstream adverse health effects. Some of these are obvious. Violence can occasionally be fatal. Sexual violence can lead to direct transmission of HIV or other sexually transmitted illnesses. But beyond that, experiencing violence fundamentally alters individuals in ways that dramatically increases their rates of other disease acquisition. Experiencing violence is associated with higher rates of adverse mental health outcomes, as well as substance abuse, higher rates of adverse reproductive health outcomes like premature birth and low birth weight infants, as well as even the development of chronic diseases at higher rates, like heart disease and diabetes. That's always surprising to people. And of course, those individuals, children who experience violence, are at increased risk of perpetrating violence at some point in their life. So violence is this condition which in many ways ties together a number of the different diseases and health conditions we all study. Our work at CDC in global childhood violence prevention largely began in 2007 when the CDC was contacted by the country of Swaziland to conduct a national survey on violence against girls. The findings from that survey were published in The Lancet. The response to the survey was overwhelming, and the country of Swaziland implemented a number of changes, everything from new legislation to new training curriculums for police officers and social workers to national level public awareness campaigns. And Swaziland, over the course of about 5 years, rose from last place, 45th, in the African Child Policy Forum country rankings to 9th on their child welfare indicator. After this survey, it really became clear that there was a large need for better information on violence against children to help countries drive policy and program change. And additional countries began to contact CDC for help conducting their own surveys. Since then, numerous violence against children surveys, or VACs, have been conducted across the world. Today, I only have time to introduce you to the surveys by presenting some very high-level results, but please see me afterward for details. Let me first say a brief word about the VACs methodology. The VACs surveys are multi-stage cluster surveys with national coverage. They're household-level surveys, typically based off each country's census sampling frame. Each VAC survey involves a broad partnership, including in-country UNICEF office, as well as multiple host nation offices. These surveys are face-to-face interviews conducted with young people ages 13 to 24, and they're conducted by same-sex interviewers. There's a number of procedures put in place to ensure privacy and the protection of respondents, and all countries now interview both males and females. In 2015, we published in the MMWR the findings from the first 7 countries with completed data collection. This was our first look at all these countries at once. And again, for these countries, after completing their survey, this was the first time they had national level data directly focused on violence against children. In this particular paper, we just focused on sexual violence against children, but the VACs are a comprehensive tool that looks at multiple forms of violence. In this table, you can see the first 7 countries surveyed. Typically anywhere from 1,000 to 2,000 young people in each country complete the interview, and overall response rates are excellent, often well into the 90 percentile range. This figure shows you those 7 countries and the percentage of young people who reported experiencing sexual violence as a child. On the y-axis is percentage, and on the x-axis is the country name. Females are the dark blue bars, and males are the light blue bars. This figure now shows you our overall measure of any form of sexual violence, which is a composite of unwanted sexual touching, attempted sex, pressured or coerced sex, and then forced sex. Now, the VACs collect data on all of these forms of sexual violence, and additional papers examine the individual types and unique patterns for each of them. There's certainly some variability here, but in general, the prevalence of sexual violence was high. On average, more than 1 in 4 girls and more than 1 in 10 boys in the countries studied. Now, not only do the VACs provide surveillance data on important outcomes like sexual violence, but they also provide information on measures of care, quality of care, and programs within a country. For example, in this MMWR article, we reported on the percentage of young people who had been victims of sexual violence and subsequently received some sort of service or treatment for that sexual violence. Despite the high prevalence of sexual violence that we saw on the previous slide, the proportion of young people receiving services was low, less than 10% in the majority of nations studied. So ultimately, as these VAC surveys are repeated, countries can use this data to see whether they're making strides in service delivery. As I mentioned, the VACs are large and comprehensive, and there's many things that can be learned from these surveys. Here are just a few papers, recent papers, specifically my own work, that you can use to find out more information about the VAC surveys. In spite of the enormous strides made over the last few years in childhood violence prevention globally, I want to close by mentioning some important directions where innovation is needed and continued growth. First, I think one of the major challenges is that an overwhelming number of global surveillance systems, including childhood violence, is still based on household surveys. I think we're starting to see a shift here in the United States with the growing importance and usefulness of administrative data or other incidental data to rapidly guide programmatic decisions. And internationally, there certainly is a need to get data faster and at a lower cost that countries can use. As one step in that direction, the Bloomberg Foundation has partnered with CDC to test the feasibility and validity of mobile phone surveys in 10 nations around the world, primarily focused on chronic diseases. And it's going to be interesting to see this data and how it compares to the traditional household level surveys that are conducted face-to-face. Now, not only might cell phone surveys be lower cost, they can also permit ongoing follow-up with individuals, which is something that's not traditionally possible with the way most household surveys are currently designed. So phones aren't just a way to collect data, they can be a way to intervene and aid, particularly in the area of violence prevention, where a lot of the interventions are behavioral in nature. We recently completed the Zambia country survey and for the first time included a detailed module on young people's access to and use of mobile phones, which I think will give us additional information on the use of these tools for both reporting and then interventions. Lastly, would say that there's also a number of process innovations happening. After multiple years of this work growing, PEPFAR has committed to this component of childhood violence prevention. The Uganda survey was recently completed and was the first country in which we altered our sampling strategy to focus on high HIV prevalence areas. And this summer in Botswana, HIV tests will be conducted in addition to the Violence Against Children survey for the first time. There's a real need to better integrate violence prevention and HIV prevention, and that's starting to happen. In closing, there's an enormous amount that can be done and still a lot of untapped insights in this data. We're working on sharing these data with collaborators, so if you're interested, please see me afterwards. I'd like to thank the many countries and hundreds of individuals involved in completing these surveys, and as well as my Fogarty mentors in the Fogarty program for preparing me for this important work. Thank you.
Concludes the presentations by our 5 alumni. Please see these folks as a snapshot, the tip of the iceberg, if you will, of many, many people who've been supported by these programs through the years. We know that in the previous iteration, the Fogarty International Clinical Research Scholars and Fellows Program, 558 individuals were supported for year abroad or in their own country, low and middle income country, research opportunities, and those numbers are continuing to mount. So I don't know how far short of 1,000 we are by now, or will be by the end of this current 5-year cycle. But the numbers are very large, and the impacts, I think we can be quite confident of. The other alumni who are not shown here today are also quite remarkable. Craig, do you have anything you want to mention, or should we open the floor for, I think it's, there is time, indeed, for questions and comments directed to them.
Hi there. My name's Aaron Yarmashuk. I'm from the University of the Western Cape in South Africa. I'm just curious on the percentage of Fogarty Fellows. You mentioned 558 as the total number. I'm just curious about the percentage that are American, percentage that are African, percentage Asian, Latin American, and European. Thank you.
I suppose we can go ahead and address that. Some of the percentages are sort of set by NIH and by the various supporting institutes and centers from around NIH. And so at the moment is weighted slightly more toward American trainees, but we do everything we can to support folks from the low and middle income countries. In the prior iteration, there was a twinning of the predoctoral folks so that there would be a low and middle income country person supported for every American doctoral student going over. That's not a part of the program currently, but we also try to achieve that whenever possible.
Hi, my name is Tulika Singh, and I'm currently a postbac at the National Cancer Institute, so I'm pretty early in my career, but I'm looking forward to applying this maybe a few years down the road. I'll be going into a PhD program this fall to learn more about immunology and vaccine development and disease transmission. And I really want to bring my global health background to research, mainly to apply it to the health of people. As I'm listening to the panel, I really appreciate learning more about your research experiences, but I'm also noticing a lot of you are medically trained. For the same reasons and same kind of research, I'm also going to be going into a PhD program. So I want to know if I'll have real opportunity in a training program like this with a PhD training only and no medical training. I think the clinical perspective is very important, but I think there's a lot of skills that you guys are bringing to the table that are also very much in the PhD realm. So I was wondering if you use your clinical or medical training, and in what ways in this program, and do you believe that this program also is very supportive of PhD trained professionals?
Do you want to?
I don't know the percentages, but one of my close friends and colleagues is a PhD and working with me in Peru. One of my close friends from my Fogarty year, the first time around, is a veterinarian. And really, it's all collaborative. So I'm sure you can get more numbers from more official numbers, but it definitely seems like multidisciplinary networking, collaborations. And Fogarty's been really supportive of a lot of my colleagues who are not necessarily MD trained. So.
Indeed, among this panel, one is a nurse, a doctorally trained nurse, of course, because you do either have to be a doctoral student or a postdoc to do this. But I'm glad you asked the question, because we really would like to have more, not only non-MDs, but non-clinicians apply to this. People from a variety of backgrounds are really encouraged to do so. And I think the representation of clinicians, the high representation of clinicians reflects the applicant pool more than it does the competitiveness, because PhD applicants are also quite competitive for these slots.
My name's Dan Young from Northwestern, and I just wanted to thank you all for presenting. I think the Fogarty program is an excellent program. I wanted to ask just about the structure. You mentioned the first iteration versus the current structure. And I know there are avenues for students and residents outside of the cohorts, outside of the consortia, to apply. And we've actually been successful in getting several students into the program, so it does work. But I have also heard the perception that like the excellent trainees at your own institutions kind of have a inside track versus the previous model, which was a national program. So I don't know if anyone could speak just about the strengths and weaknesses of the structure of the program.
Well, I graduated not from a school that was in my consortium, but I reached out to who was to become my mentor, and we very quickly established a relationship and wrote a proposal that was successful. So I think that model worked for me.
So maybe I'll just speak a little bit to that point as well. It's very well taken. So I believe of the 5 existing consortia, and we're going to be going through a competitive process in the very near future, all but ours will accept and encourages people to apply from a multitude of institutions within the U.S. and, of course, the international partner institutions as well. Ours is focused on developing the pipeline of global health researchers and leaders within the University of California. And so for that, we have 10 campuses and our international partners, so we've limited, but we're the only one of the 5. But I understand your point. If you're at an institution that's not currently within, or what will be eventually within the consortia that get funded, there are some additional challenges. But I just want to speak about myself for a moment. I was actually a resident in OBGYN at Northwestern before global health was on the map within the Chicago area. And it was through connections with a faculty member in my department who knew somebody at CDC, Ann Doerr, who's now up in Seattle, and Kenrad Nelson, who's at Hopkins, a very senior researcher there, that I was able to put together what became my initial research which was looking at the effects of HIV infection on women living with or having bacterial vaginosis. And I, on my own dime, flew to Atlanta on one trip, on my own dime flew to Baltimore on another trip, had my resident colleagues to take that up. So, and then on my own dime, I flew to Chiang Mai to work with them for 6 weeks, and here I am today. So when I have individual students, residents, and postdocs come and to me with their own interest, I take everyone. I mean, okay, the global health, this is a competitive process, but as far as at UCSF or from our colleagues in Kenya, I take anyone at face value. And then I give them a set of tasks essentially to do. I give them materials to read, I have them think, and so forth. And as long as they meet that metric and go the extra mile, I mean, I don't say no to anyone. So it's really, from my perspective, kind of incumbent on you. There are additional challenges if you're not sitting at one of the institutions that has the funding and has the linkages to the international site, but it's all doable, right? It depends on the consortia, how the consortia are going to be funded. So I don't know if you want to add anything. But.
Thank you very much for the nice presentation. My name is Johanna Mashala. I'm from University of Botswana, Faculty of Health Sciences. I wish to congratulate, Fogarty for the wonderful, contribution towards building capacity in the different areas. And for you guys, you have performed wonderfully, and I really pray that you'll keep it up. And we are looking forward to seeing you even more coming also to some of our areas in Africa. Now, I have two very quick questions. One, I think, is to Christine. About lung decay and biomass. The lungs normally should grow, reach a plateau, and decay. Now, in your case, you reported that you did observe lung decay in those who used biomass fuels. Now, just want to clear my mind that to what extent, what is the rate of change or rate of decay that you observed? And what was the age range of your population that you studied, so that at least you do not, include the normal lung decay as part of the what you observed as as a percentage of lung decay. Now the second one is, I think, to the last presentation. I think is Steve. You'll be coming to Botswana? Is it this year, next year? And which institution or who are the local contact persons that you'll be working with? I would like to know that. Thank you.
I guess I can start with the biomass and land decay question, and that's a very good question. It's one I actually don't have an answer to yet. So as part of our larger NIH study moving forward, we're looking at 200 families. So there's a lot more cost, benefit, and burden investigation that's going into that to actually look at time spent gathering supplies for biomass, what the effect is on their agriculture. There's rainy periods, there's rainy seasons in Peru where they can't get enough dry substances to actually burn for biomass, and they're using a lot more plastics and trash. So we have a team that's going to be investigating with us, looking at that specifically. During my study, it was it started at the end of the rainy season and went to the beginning of the next rainy season. So we don't have a full year to capture that data yet. But over the next study, it's over 2 years. So we'll have time to go over 2 full cycles and seasons to evaluate that. And as far as the age range, we were looking at women 35 years and above. Trying to get a younger group of women, evaluating a younger group of women, because we really see advanced disease at a younger age, and that's what we are trying to intervene on and change. I'm not sure if that fully answers your question, but moving in that direction, and I'm really glad you bring it up because it's a huge part of planetary health, and that's what makes my piece just such a small part of a really large puzzle. So thank you.
Thank you also for your interest in the Violence Against Children surveys. I think the Botswana survey ideally will start June if all continues to go as planned. I'm personally not leading that survey, but stop and see me afterwards, and I can give you the contact information for the one who can put you in touch with the leaders at CDC and in country.
Hi, good morning. My name is Olivia Cheng, one of the third-year not medical student, OBGYN resident. I worked hard. Third-year OBGYN resident at Beth Israel Deaconess, one of the Harvard Medical School teaching hospitals in Boston. So thank you so much for this talk. It's so inspiring while all my co-residents are signing private attendingship contracts, so this is great. I needed to be here. I have two questions. The first one being, are there any thoughts of really maybe incorporating medical education into these fellowships, since that some of the fellows may have completed residency at the time they go abroad? Is there any thought of maybe attending while abroad at the same time while doing a research? Is that a possibility that could be explored in one of the coming applications? And my second question is for Christian, or Dr. Meal as well. I also have interest in pursuing a fellowship, and one of the things that I worry about is, after I do a Fogarty year, would I still have the opportunity and time to pursue and continue the research during fellowship, and whether you've had any challenges in doing that?
That's a really good question, and that was a large part of why I chose to do my fellowship where I am now at Johns Hopkins. It's something you have to think about when you're applying to fellowship. So I wanted to be at a place where whatever research I started out as a Fogarty Fellow, I could continue through my whole fellowship and really build upon. So I made those connections at the forefront. I did not apply to fellowship until I knew I actually applied to fellowship at the same time I applied to the Fogarty program. And I made sure to talk to all of the program directors at the places I applied, letting them know that I'm applying in this round, but I want to defer for a year to set up my research. And that actually worked at Hopkins. Both Johns Hopkins, my home institution, UCLA, University of Maryland, everyone was really flexible, the places I was really looking. But it was something that I advertised as like, look, I want to be in academia, I want to be a global health researcher, and this is my plan. So I find when you come to interviews with a plan, it's a lot easier to have that discussion. Now, I was a bit of a gamble because I didn't know I got the Fogarty until a week after I got into fellowship. So you gotta really talk to collaborators, talk to mentors, and really get that in the forefront first. But it's a lot of conversation. I'm really happy to talk to you about the process I went through. I have a friend in OB who's done it as well. So I'm happy to put you in touch with her. So please contact me afterwards and I can make connections.
The question about medical education.
Yeah, I think your other question was about incorporating, if I understood it right, incorporating other educational opportunities and even degree studies within this? Is that what?
Well, there's an organization called C Global Health, and Global Health, I think that's their name, and they're sending essentially young attendings abroad to serve as attendings in foreign countries, and essentially they mentor medical students and residents. So is there any way that people who are Fogarty Fellows could conduct their research and also dual in that role?
Good. This is really designed to be a full-time research-intensive experience, and the SEED Global Health Program is a wonderful one, but it has very different objectives and focus. So you wouldn't be able to do them in tandem during the same year. You'd need to do them during separate years. But it'd be interesting to know how many people had done one and looking forward done one and then done the other one. This one really requires full-time, at least, well, it's typically 11 months in the country doing the research and really focusing full-time on research.
Okay, thank you.
Mm-hmm.
Thank you. My name is Chim. I'm also an OBGYN resident. Really excellent presentation. I was part of the Doris Duke program in medical school and did some work with Fogarty. My question is, so it's a one-year fellowship, which is excellent, but as most people who are trying to get onto sort of a research academia route, a year is not quite enough to do research and to publish and to be able to set yourself up for sort of this traditional path. So are there any opportunities for making this more traditional 2 or 3 years, which generally is traditionally what's needed to kind of set somebody up on a traditional career path? Thank you.
Thank you. I had the same concerns, and with the very small begging to Fogarty and a very large begging to my department. I was able to stay an additional year. And it meant an extraordinary amount for me professionally, but more importantly for the programs that we were trying to develop in Ghana, and our team development and getting things to where they would run a bit autonomously. And the publication thing, of course, is important, as Dr. Zund, who runs our consortium, says. It's the currency within which we work. But it really is more than that. It's about creating relationships, networks, and programs that will last well beyond your stay. So there is opportunities for that. I think the competitive renewal is going to potentially allow more opportunities for that through at least some, if not all, the consortia. So definitely 2 years is a possibility.
And to add to that, what the Fogarty's done a great job doing is they really set up training for you to take that next step on your own. So we had workshops and webinars on grant writing, getting your CV together, getting everything together. And actually during my Fogarty year, I applied for further NRSA, which is at F32 grant funding, to continue this work independently. But I was also protected because I chose a fellowship program that would allow me to continue that research. Travel's hard. I've gotten really connected to Hopkins Global Health system and program so that I can still continue to travel between my clinics. I have to stack up clinics, but a part of it is if you have further training to go on to find the locations and the mentors who will support you and help you with that flexibility, because it's more than a year-long process. What you invest in as a Fogarty Fellow should set you up for years after that. Your research, but like Barclay said, really for the site and for contributing back to the communities where you're researching.
Hello, Ashley Pickering. I'm currently a medical student, MD, MPH at U of A. My specific interest is in emergency medicine globally, and I know that this is a newer field within global health. So in thinking about applying for a Fogarty, is it most important when you're looking at which consortium to apply for to look first for a mentor that has your interest internationally or within the consortium here in the US?
That's also a very good question, and further to this point of applying for one of these from outside the consortia. The way this is designed, and the reason it's restricted to certain universities within consortia is with an attempt to link the scholars and fellows who go out with existing research projects in well-funded research sites that are connected to the university's funded through consortia. And so you would want to look, really just review the literature in your, the entire literature for that matter, in your area of interest and see what linkages you can find with both, potentially with both one of the universities in the consortia as well as one of their sites. But you couldn't bring in, well, it's unusual to bring in a site that's not already part of it, an LMIC site that's not already part of a research collaboration of a U.S. institution that's within one of the consortia.
Also just point out that the various websites that are indicative of the various programs specify the list of international LMIC institutions that are connected with each of the consortium, and there they specify what research is ongoing currently and in regards to mentors that are available as well. So that should be your first step or first stop, is to actually look at those websites. For example, UCSF has a partnership with MUHAS in Tanzania, led in part by Terry Reynolds and her counterparts at MUHAS. She's now at WHO, but she's an emergency medicine person. So that's where people interested in our consortium, I steer them in that direction. I'm sure all the consortia have connections to emergency medicine. I think, Kemtai, I think we have to hold questions. I actually need to run to the airport, and I think we want final word from Roger Glass. Sorry. And Kemtai, you have access to me at any time, and you can come up afterwards here.
Let me just, is this on? Yeah. Let me just thank the presenters. I thought that was exciting. We're looking forward to seeing what happens. And it was clear from the presentations that you've learned a lot about research. You've gotten culturally sensitive. You have a future. I think of the 5 of you having 40 years of career in front of you. That's like 200 person years of research in global health. So we're really looking forward to what you're going to contribute. Also, so I think that's really... Second, I have a couple silent moles in this audience, Flora Katz and Peter Kilmarks. But will you stand up, please? Flora is the project officer for this right now, and Peter's my deputy. They do an amazing job with this program and with the orientation. Peter spent 2 years in Botswana. Did somebody work in Botswana? And Zimbabwe and other places. So they really have a lot of experience. They support this. The mentors have been awesome. And I think those mentors on both sides, the ones that you see, but also the ones that you don't see in the countries and on universities, and that they're amazing. Without them and crazy people like Doug with a passion for global health and Craig, but they're just 2 of dozens. So, and our NIH partners, we have 18 institutes and centers at NIH involved in this. Really a diverse group. And if you have interesting people who want to do research in global health, whether it's PhD or doctors, dentists, or engineers, we are open to your suggestions. Really good people who have that commitment. On the what you can do in terms of service, we've had an OBGYN, Jennifer Tang, who went out to do research, got so involved in the research and teaching that she stayed for 2 years and now has a training and research program in Malawi with a link to, I believe, UNC. So there are other opportunities. There's a future. We have K Awards for young investigators, both U.S. and foreign. So there's a career track to get you started and give you a head start. And I think this is really a growing field, and I think the presentations blew me away, every single one, and I'm delighted to see the diversity and what you're doing. We're going to track you. We want to track you for the next 40 years, and make sure you help us next year when we have our 50th birthday party for Fogarty, and we begin right here, and also the 15th anniversary of this Fogarty Fellows and Scholars Program. Thank you so much. I'm thrilled with what's happened here today, and great presentation.